All right. Head and neck cancer management in North Carolina with Dr. Blake Sullivan. And we've got a more comprehensive bio, but we're going to pick some of the top things to know about Dr. Sullivan. Dr. Sullivan, welcome. We're really glad to have you here today. Thank you so much.
Thanks for having me, Tim and John and Lineberg. I appreciate the opportunity to talk about an important topic.
Absolutely. So you're an assistant professor in the Department of Otolaryngology, Head and Neck Surgery at UNC Chapel Hill, and your specialty interests involve head and neck cancer, benign head and neck tumors, salivary gland tumors, robotic surgery, and complex microvascular reconstruction. An active role in research pertaining to surgical outcomes, and serves as educator for medical students and residents and fellows, and received a Bachelor of Science degree from Lipscomb University and medical doctorate from Oregon Health and Science University, and completed otolaryngology head and neck surgery at the University of Iowa and additional fellowship training at the Cleveland Clinic Foundation. That's impressive. Anything we need to add to that, Dr. Sullivan?
I have a 3-year-old and an 8-month-old at home, so those keep me the most busy and active. So
I can only imagine.
Yeah.
Good for you.
Yeah.
Good for you. Well, I mentioned poll everywhere. So the first question, and this is kind of a softball just to get everyone, especially if you're new to these lectures, get you comfortable with using poll everywhere. Head and neck cancer is a general term for cancers that can develop in the head and neck region. I'm going to flash up our disclosures. All right, and it's interesting. It's displaying. It's interesting. I'm not sure what it's up to there, but it's doing something a little odd and not. We're showing 100% true. Bear with me for just a second. I'm going to try resharing because I'm not liking what I'm seeing on the screen that our audience is seeing. So let me go ahead and share again, see if we can address that. Okay, it's still acting up a little bit. Once in a while, Poll Everywhere does this for us. Yeah, we'll see what happens when we get to the next question. And worst case, we'll just let you know how people are doing, and I can share that information. All right, so without further ado, oh, there we go. Now it's working. So we've got 100% saying true. Is that right?
I think so.
All right. Sounds safe to me. So head and neck cancer in North Carolina. Dr. Sullivan, we'll let you take it away from here.
Thank you, Tim. So I'm just going to give a brief overview of head and neck cancer today. This is a 30,000-foot overview, and you could require years of education to try to go over this topic. It's a very complex topic, but we'll stay broad today. And so we'll talk about head and neck cancer demographics, specifically to the state of North Carolina and rural populations, because that's where the majority of our patients come from. We'll touch on the treatment modalities, which include surgery, radiation, systemic therapy. Systemic therapy combined with chemotherapy and immunotherapy nowadays. More of a personalized approach. And then we'll talk about clinical trials that we're actively doing at UNC and Lineberger with the otolaryngology department, radiation oncology, and medical oncology. And then talk about future directions in this field. It is a field that historically has potentially lagged a little bit behind on research until recent years. And so there's been some very promising results coming over recent years with head and neck cancer, and it's an exciting time to be a part of it. And it's still a very challenging time to be a head and neck cancer patient because the outcomes are not sometimes what we as healthcare providers want. And so head and neck cancer, it's the seventh most common cancer worldwide. And so it's one of the more common ones we take care of. And when we're talking about head and neck cancer, it's a variety of diseases that we treat, which includes the oral cavity, the pharynx, the nasal cavity, the larynx or voice box, the salivary glands. And then not always the case, but sometimes we include endocrine, which we may touch on just a little bit depending on timing, and cutaneous malignancies. Those are often not included with a lot of the data that we look at, but it's something that we as providers take care of. And then the main drivers for cancers of the mouth and throat, so what we call the aerodigestive tract, has historically been alcohol, tobacco, and in other countries such as Southeast Asia, something called betel nut. We'll see that occasionally in America. It's not often. And then people that have a strong history of alcohol and tobacco use, it's a synergistic effect. So the effect is multiplicative and it's not just additive. So that's important if you're potentially screening patients for head and neck cancer. And in the developed countries nowadays, HPV-mediated disease is more common than our HPV-negative cancers. And these are often people that are never smokers or minimal alcohol use that will come into us. They tend to be younger, more robust, and we see a lot of those patients nowadays. And head and neck cancer is I like to describe it as it's a very personal cancer. It has significant psychosocial effects on the patient, their family, because the way that we as humans interact with people is through our senses, our face, our mouth, our speaking, and head and neck cancer can undoubtedly affect either one or all of those senses. And so it's a very personal cancer and can have profound impacts on the patients as they're undergoing treatment and long term. And so that's something you often have to keep in mind. And so the first poll question would be, the majority of new head and neck cancer cases present as early stage disease, true or false? Give it a few more seconds. All right. So the majority of respondents say that that is false, and that is true. 2/3 of head and neck cancer, whether it's in North Carolina or nationally, present as late stage disease, so stage 3 and stage 4 disease. So a lot of times we are seeing people with advanced disease, and that makes it challenging. Head and neck cancer in the United States, 2 years ago, there's over 54,000 cases. There's over 11,000 deaths. And like I said, 2/3 of people will present with advanced disease. And that's important because, as you'll see, the survival curve dips off dramatically as someone presents with either advanced local regional disease, so cancer in the head and neck, not just confined to, say, the mouth, or distantly, often the chest, the lung, the bones. And those people have they present a very poor prognosis. The 5-year survival has improved a little bit over recent years. It's roughly 69%, but that can be anywhere from about 25% to up to 90%. If it's locally advanced if it's localized in the mouth, it tends to be closer to 87%. If someone has disease into their jawbone or distantly spread, that can drop off to about 25% survival in 5 years. The incidence is 3 times much higher in men, but we do see a lot of women that are never smokers, a younger population of females that have never smoked that get this cancer nowadays. It's an active area of research, and we don't know why. And this seems to be independent of the HPV-mediated disease process, but there is an increase in that within what we take care of. And this is a survival graph here. And so if you have localized disease, you still have a very good chance of being able to fully eradicate the disease. But if you have locally advanced regional disease or distant disease, the survival advantage drops off precipitously here. Head and neck cancer in North Carolina. So we are a very busy center here for head and neck cancer, one of the busier ones in the nation, one of the busiest in the region. And part of that is because a lot of our patients come from rural locations. North Carolina is still considered the second most rural population in the United States per capita, which is a little bit surprising. It is behind Texas. And so a lot of times our patients are coming from far away. And because of this, a lot of these people don't have as either robust of insurance or they don't have insurance, period. And so that makes undoubtedly their care much more difficult. It can lead to significant delays in their care or getting certain things covered. And 40% of our state's population is rural. So even though we live in the Triangle, which is a very overall wealthy area, a lot of our patients are very underserved economically, educationally, and it makes it a challenge to get their care expedited. So they estimate about almost 10% of residents lack healthcare coverage, which is a significant component of our patients. And then one thing that we're finding out more days now of is that oral health plays an important role with potentially development or recurrence or advancement of head and neck cancer. And the state of North Carolina, over 2 million people struggled to get dental care. And that's pretty significant because a lot of our patients, you'll see that they have poor dentition, and does that lead to potentially developing the cancer or the immune system not being as robust? The microbiome in the mouth we're probably going to find out a significant role in aerodigestive tract cancer. Head and neck cancer in North Carolina, it's about 9 people per 100,000 people. So it's not common in the general population, but it's very common for us as otolaryngologists. So that's over 1,100 patients annually in the state of North Carolina. And the majority of these as well present as late-stage disease. So the numbers are similar compared to the overall United States. Access to care in North Carolina and nationwide can be difficult for head and neck cancer. A lot of the treatment modalities require a variety of healthcare providers, physicians, and some of these treatments that we do, you're requiring 2 physicians, occasionally 3 being involved with the surgery, so coordination of care is quite challenging. There are significant geographic barriers that these people have to overcome to be able to get here for biopsies or imaging modality. It often leads to multiple people having to see the patient leading up to the definitive plan. And so the workup itself can take 2 to 3 weeks sometimes. And while that's going on, that is, ultimately delaying their care. And the diagnostic workup for head and neck cancer can be quite complex. We have to have biopsies, and so we have to have biopsy-proven disease. We have to have it of the primary site. Sometimes we'll get it of other sites as well if we're not sure if that's relevant. Sometimes people will come in with advanced disease to where they have lung nodules. And so we have to sometimes biopsy those before we undergo treatment, and that can delay our treatment. And so it is a challenge to get these people treated in a timely fashion. And a lot of these patients, they can have significant comorbidities to where they need to go undergo medical clearance, a cardiac clearance to hold anticoagulation before surgery. And so they're having to go back and see their cardiologist or their PCP. And that can certainly put up roadblocks to trying to get people in a timely fashion. Or they may had a patient the other day we had to cancel, and they had to undergo a cardiac cath. And so their surgery was scheduled for 10 hours with 2 surgeons, and those things are hard to reschedule. And sometimes the surgical date here, it's pretty good. We can typically get someone in the OR in a couple weeks, which is a good time frame. There's other places around the country where the wait can be 6 weeks, sometimes up to 2 months because of the way the hospital system is after COVID. It's just much more challenging to get these people treated. A lot of this advanced head and neck cancer, a lot of the care occurs at high volume centers. And so a lot of the data nowadays is looking at what are the outcomes of people, whether they get treated in the community, either with intense radiation, intense surgery here versus in the community. And so this was done here at our university a few years ago. And essentially they were just showing that surgeon volume, whether it be at an academic center or a cancer community hospital with high volume or a non-academic center, those people tended to do better. And then the academic centers, which tends to get the most advanced disease, those patients benefited the most when it was late-stage disease. And so one of the big pushes over recent years for cancer care has been screening. And at UNC, we have an annual screening process at the university and in the community. It tends to take place in the springtime. However, pan screening, as far as the data suggests, tends to maybe not be overly effective because you have to screen such a high number of people to try to capture the very few people that have cancer. And so Schumann et al. At Michigan looked at a study of over 1,500 people a few years ago, and out of that, they only got 3 people that were diagnosed with malignancy. So that's a very time-intensive, labor-intensive, person-intensive screening process. But there are ways to try to narrow the screening, whether you're in primary care, advanced practice provider, to look at that patient population and say they would potentially be at a higher risk. And those are people that have strong tobacco, strong alcohol, poor dentition. If they have a spot in their neck, a spot in their mouth that's not healing after a week or 2, those are the people that we should really hone on. So it should be more of a targeted screening process. And we don't have time to go into the details of this, but if an area is going to screen, it should look at very specific risk factors to try to make the resources available to capture cancer patients or precancerous patients. So now this part of the talk, we'll talk about treatment. And head and neck cancer treatment is very complex. It's complex because we have to remove the cancer, we potentially have to remove lymph nodes, and then we have to work on reconstruction. And so that's a significant component. And head and neck cancer is different than other types of cancers that we take care of. It's different than skin cancers. It's different than, say, abdominal cancer or cancer of the joints, is because these significantly can affect someone's functional components of their body. So mostly speech and swallowing, and then their aesthetic outcomes. And those are hard for us still in the modern age to reconstruct in a good fashion. We've gotten better, but we're not where we should be. And so a lot of times people come to centers such as this because more so of the reconstructive needs. It is a very challenging part of our job to be able to do that well. And so in the state of North Carolina, there's UNC, there's Duke, Wake Forest, Atrium Health, Eastern Carolina, and Mission Health in Asheville is a newer place. And then there's Charlotte, Sienta, to where all of these places pretty much take care of advanced cancer care. And that's for the state of North Carolina. UNC is by far and away the busiest head and neck cancer practice in the state of North Carolina, and one of the busiest in the Southeast, if not the nation. And so when someone comes in with cancer, I often tell them there's three ways that we treat cancer. There's surgery, there's radiation, there's chemotherapy / immunotherapy, and it often has to be a multimodal approach. The majority of our patients are not just getting one treatment modality. They're often getting a combination, and that depends on the cancer, what their overall health is, and what are the functional implications going to be. And so that's where we're at nowadays. Surgery is the mainstay of treatment for a lot of head and neck cancers still, primarily for cancer of the front of the mouth, what we call the oral cavity cancer. Surgery is the mainstay of treatment. It is rare if someone has cancer in the front of their mouth, so their lips, their cheeks, or their tongue, or the roof of their mouth, or the bottom of their mouth, that we do chemo and radiation as the primary treatment. Now, a lot of these people will get chemo and radiation after surgery, but the data still tends to suggest that the people do best if surgery is the upfront treatment, followed by possible adjuvant therapy. In surgery in head and neck cancer, it requires removal of the primary tumor and then questionable removal of the lymph nodes. The lymph nodes is a ever-evolving topic, and we have a clinical trial that's trying to address that. And then we also have to think about reconstruction. You never want to impact your oncologic cancer removal based upon what type of reconstruction you can do, especially because we have several reconstructive surgeons here nowadays. And this can lead to significant impact on your senses. It can affect your aerodigestive tract, your neck. The neck is really important. From a functional perspective, people can have long-term sequelae either from surgery or radiation. And we want to try to minimize the morbidity of neck surgery. And then we work around a lot of cranial nerves. I'm doing thyroid cancer today and a couple of young women. And so we have to be very important that we preserve their recurrent laryngeal nerve, because it could be devastating from a speech and swallowing standpoint if we were to damage those nerves. But those are the things we often think about. And so what are advances here at North Carolina and nationwide that we've made in surgery in recent years? It's a neat time to be a part of cancer care and head and neck cancer care. And so this is a clinical trial that we're actively participating in that is trying to limit the amount of neck surgery that we can do in patients if we need. And so there's something called a sentinel lymph node biopsy that is not routinely done for head and neck cancer. It's done a lot nowadays for other cancers, breast cancer, melanoma. And a neck dissection can potentially lead to a lot of morbidity because we have to work around several cranial nerves. We work around the great vessels, the carotid artery, the jugular vein. There could be infection. It can impact your neck range of motion adversely. And so what this trial is trying to identify is, can we take people with early stage, so what we call T1 or T2 cancer of the mouth, the tongue, the cheeks, the floor of mouth, and can we potentially do a sentinel lymph node biopsy to decrease their morbidity while also making sure their survival is superior. So it's a phase 2, phase 3 trial with multiple institutions in the United States. 20% of people with head and neck cancer will have what's called occult metastasis. You'll see them in the office and they have no evidence of clinical disease. You can't palpate any lymph nodes in the neck. And then we get a cross-sectional imaging, usually a CAT scan, occasionally an MRI. But then they're found afterwards to have cancer in their lymph nodes after they've had a neck dissection. And so we're still trying to figure out what the best way is we can treat those people with. And so the goal of this trial is to try to see, is sentinel lymph node biopsy, is it not inferior relative to a neck dissection? And so the primary endpoint is disease-free survival. And then we also want to address what is the person's shoulder quality, what is their neck function, and their overall quality of life. And so myself and a partner are enrolled in this trial. The other part of head and neck cancer that's really neat is over the past about 15 years or so, robotic surgery has revolutionized how we treat some cancers. It's often cancers at the back of the mouth. That's a picture of when I was in fellowship. And so it's really revolutionized what we call pharynx cancer. And it's been very helpful for people that had HPV-mediated disease. So they have relatively confined disease, but we can't get our hands back there without doing a very morbid surgery. So we can use the robot to remove that cancer and select patients. It's not applicable to everybody, but there are a lot of people it could potentially be useful for. And so the sites of disease that we use this to treat is called the oropharynx, so it's the back of the throat, the retropharynx, that's the middle of the throat. Occasionally we do something called the parapharyngeal space, which is deep up near the skull base, and those spots sometimes can be challenging to reach from the neck in a safe fashion. Other places, occasionally we'll do it in as the voice box or around the voice box, so called the larynx or hypopharynx. And then in pediatric populations, so some children will have stuff that's amenable to robotic surgery. And then a couple of us do robotic surgery here. And the nice thing is, for example, tomorrow I have a lady who has HPV disease of her tonsil. And essentially, if we can remove the cancer from the tonsil with the robot, she either is potentially going to get less radiation. There's a chance sometimes people get no radiation. Limit chemotherapy. And so these types of things can help minimize the impact and improve someone's quality of life. And that's not only improving survival, we're really trying to see how can we improve somebody's quality of life. And in our tumor boards every week, it still can be a back and forth of which treatment modality is the best, because even though it's minimally accessed, robotic surgery does have advantages, but it has disadvantages as well. So this is a similar picture of the robot that we have here. It's a state of the art. It's really great. So the advantage are it's minimally invasive. You get excellent visualization of your field and the tumor specifically. It helps to scale the hand movements of a surgeon. So even the best surgeons in the world have a tremor. Every person in the world has some type of tremor. And a lot of the work we do, you can see it under the microscope because it's just such fine detail. And the robots help to minimize that. This can help limit your deficits in speech and swallowing. It can help decrease your length of stay. Before the robot was available, if someone needed a surgery in this area, the jawbone would often have to be split. Someone would have to get a tracheostomy tube, a feeding tube in their throat, potentially their stomach. Those hospital stays are usually at the minimum 2 weeks. Nowadays, if people have this robotic surgery, some people go home 3 days, 4 days after surgery can be pretty common. And so their quality of life can be much better. And wound healing can be much better as well because it's limited incisions that we make. Now, there are disadvantages to this. Availability to the robot. So we have a robot here. We have to share it with other services. So, sometimes that can lead to a little bit of a delay. There is a risk of major bleeding with this type of surgery. So that's something we always worry about with surgery at the back of the throat, because there can be major blood vessels from the carotid artery, and we have to try to minimize those risks. We do a few things to try to minimize risk, but still there can be major bleeding and it can be life-threatening, and it does happen. So that's something people have to be aware of. And as an oncologic surgeon, part of the way we still remove tumors in the mouth, in the operating room, is we have tactile feel of the tumor. We need to see the edges, that the edges feel okay, that they're clear. And a lot of that is by your proprioception, feeling the tumor, analyzing the tumor. And with the robot, we don't have that available right now. So sometimes you fully have to rely on your vision, and that can be challenging in certain environments. So not having haptic feedback is a downside to this. And it's something that they're working on trying to implement. It's still probably a few years off of being able to do that. Now we're going to shift towards reconstruction. reconstruction head and neck cancer is quite complex. So a lot of us did advanced training for reconstruction purposes. The main things that we want to do are we want to restore form and function. When we operate on someone, the most important thing is that we give them a safe airway. So if you're taking care of a head and neck cancer patient, swallowing is not the most important, aesthetics are not the most important. The most important is that they have a safe airway. And that's to help them breathe, but also to help them try to prevent them from aspirating, because aspirating can lead to life-threatening pneumonias, and a lot of our cancer patients can have significant impacts from aspiration that can ultimately be fatal. And once there is advanced aspiration, there's only really a major surgery that will fix that, and it's life-altering, and sometimes people don't want that. After that, after we've established a safe airway, we want to have a safe swallow. We want to try to make their speech good, or as best or as intelligible as we can. We want to work on aesthetics. And then we also want to try to minimize the donor site morbidity. And what I mean by that is if we have to remove a tumor from the head or neck, we have to replace that area. And a lot of times what we do are there's these called auto transplants, or some of you all know they're called free flaps. They're not skin grafts. And so what we do is we take either bone, muscle, skin, fascia, or a combination, and we take the blood vessels as well. So it's just like a heart transplant, just like a liver transplant. It's actually a little more tenuous because the blood vessels are much smaller. And so it's a very advanced surgery. And so we want to try to minimize the donor sites that we borrow these from. So we want to make people better, be able to help them walk better, use their shoulder better. And so this is just an example of one thing that we do. I do a lot of what's called a fibula flap, and this is the fibula bone here. And so we harvest this bone, and then say if we need to resurface the lining of someone's mouth or their skin, we can take skin or fascia from the outside with the blood vessels attached. And then we essentially can recreate a jawbone. We can recreate someone's nose, their midface, other rare things that we do with this. And then these blood vessels from the leg, they get transplanted to the blood vessels in the neck or the face, and that's what keeps the graft alive. And that requires advanced surgical training. And really nowadays, this is called auto transplantation. This should be the gold standard for someone with advanced head and neck cancer care. These cases vary in length. They're typically 8 to 12 hours long. Sometimes they can be a little bit longer depending on the complexity of the case. And so it's not a trivial thing for one to undergo. We often do a two-team approach. And so that means someone is focused on removing the cancer, removing the lymph nodes, or removing whatever problem they have that day, whether it's trauma, infection. And then the other surgeon is working on the reconstruction. That leads to less anesthetic time. It means each surgeon can focus on their task and not potentially have a shortcut with their part of the surgery. And by doing that, that allows each surgeon to focus a little more. And these cases can be pretty tedious. So the burnout rate should be less with these cases. And these types of surgeries, they require intense postoperative monitoring. So with the surgical team, with the nurses, the advanced practice providers, the whole team, it really requires the first several days that everybody is doing intense monitoring in these patients, because complications do arise. These grafts do fail occasionally. Usually nowadays there's about a 95% success rate, but that's still 5 out of 100 people or so that will fail, which is not small. And these people require extended hospital lengths of stay. So usually the minimum we keep people is 7 days. Some people are admitted for 3 weeks or more based upon their outcomes after surgery. This is an example of a patient I did a few months ago. They had a cancer within their jawbone here, and this is their tooth here. And you can see there's erosion, what we call scalloping of the bone here. And anytime the cancer has been either invaded a dental socket or into the bone, we have to take what's called a full segment of bone. Otherwise, we would be not doing a thorough oncologic resection. And because we have to take a full segment of bone on either side, we have to reconstruct. And so what we did here was I took a fibula graft from the patient's leg. And so this is their fibula bone here. Made it into 2 pieces here and to fit the defect here. And then this is a reconstruction bar. And so he's actually done really well. I saw him a week or 2 ago. This is a nice case. He's had a really nice outcome. And you can see there's minimal changes to his skin subcutaneous contour here. So he was left with a really nice outcome. One of the things we can do with some of these cases is something called virtual surgical planning. And what that means is we can essentially develop a template of our problem, whether that's we have the 3D lab here or a company that works with us, and say if we need to remove this segment of the jawbone, they can identify that. They can make us custom guides for cutting if we need. And then that helps us out because we already know where our cuts are going to be going into surgery, so it saves us time thinking about it. So it just makes the day tend to go a little smoother. It doesn't always work out perfect. And then say, well, my partner's doing this, I can go to the leg and I can simultaneously start harvesting the bone even before they've cut this out because we've developed cutting guides to show us exactly where to cut. And that makes it really nice. And so this is an example of another patient. And you can see here they have their jawbone reconstructed with their leg bone, so fibula. Another common thing we do is a scapula bone. But this person can have a really nice outcome and it can decrease operative time. And anytime you can save operative time can save the hospital money. So it's something that we try to do. We can't always do it, especially with advanced cancer cases, because things can be different when you get in there. But for cases that have trauma or osteoradionecrosis or limited cancers, it can be helpful. One of the things that's hopefully going to potentially revolutionize head and neck cancer surgery will be image-guided surgery. It's still in its infancy, and there's only a few places around the country that are really diving in deep to this. But the problem is that surgical margins in head and neck cancer can still be quite a challenge to take care of. So positive margins, meaning leaving cancer in the patient, can still happen around 10, 15% of the time. So if you're taking out cancer, a 1 in 10 chance or more that you're going to leave cancer behind. And the data suggests that even if you, after you cut the cancer out, if you have cancer present and you go back and clear it again, those people still don't do well. That's a time for a different discussion. But we need to get better at removing the cancer during the initial resection because we know that that specifically adversely affects someone's disease-specific mortality. And there's specific things that are being done, such as fluorescence, molecular imaging, so potentially doing administration of fluorescence-guided tags to help identify the edges of the tumor. And there's real potential that this could revolutionize surgery. It's still several years off, but it has real promises. And so the goal of this would be to only highlight tissue that's either malignant or highly pre-malignant. You don't want to highlight normal tissue, so you want tumor-specific tracers to try to keep as much normal tissue as possible. Complications after head and neck cancer. So I tell patients pretty much if they're going to undergo one of these bigger surgeries, it is rare for someone to have head and neck cancer treatment and not have at least a single complication. There are always bumps in the road, even for the healthiest people. It's because we're working in an environment where people are moving their aerodigestive tract. So with speech and swallowing, they're constantly moving the muscles in their mouth. They're tugging at it. There's saliva. Saliva is a thing that will break down whatever suture line that you have. And there's also patient compliance. People really want to eat. People really want to drink. And so those can break down our reconstruction. So we always have to think about what are the complications. Before you do a reconstruction, you need to think about, well, what are the complications that could happen afterwards? And so I have a surgery on Monday with a partner for an advanced voice box case. And yesterday we were going over, well, if they break down, we should do this, And so we always want to keep that in the back of our mind going into surgery to try to minimize those complications if we can. Sometimes they're unavoidable. And one of the important topics is something called osteoradionecrosis. So here's a question. Osteoradionecrosis is a rare complication after head and neck cancer treatment that often resolves with antibiotics alone. All right, so that is false. This can be a challenging problem to treat. Where I did my fellowship, one of my mentors has kind of revolutionized treatment to this. So it is a promising area and something that people who take care of head and neck cancer patients should be aware of, because a lot of times this will be sent to us from dentists, primary care providers, internal medicine physicians. They'll catch this in the survivorship phase. So osteoradionecrosis, it is a late complication after radiotherapy. It sometimes occurs a few months afterwards, but tends to be a couple years afterwards. I saw 2 patients with it yesterday. It can lead to serious, profound complications. The pain can be really bad. Sometimes these people are in worse pain than cancer-related pain. It can lead to the jawbone breaking, so what we call a pathologic fracture. It can lead to significant infection, so infection in the mouth. The infection can drain into the cervical skin and lead to what's called a fistula, so a draining hole. Those are really hard to treat sometimes. Can lead to swelling around the problem. It can also lead to trismus, so difficulties opening your mouth. And anytime someone gets trismus, it is very hard for us to fix. We can fix other things nowadays. There has not been a development to fix trismus in a good way yet. So even if we do a big reconstruction, trismus undoubtedly still often comes back. And so historically, the treatment of osteoradionecrosis has been challenging. The American Society of Clinical Oncology put out a statement about hyperbaric oxygen therapy. So a lot of times these patients will get treated with hyperbaric oxygen therapy before they come to us, and it's historically been a treatment modality employed to try to limit a major surgery. And we understand why, but the data suggests nowadays that there's no benefit to support hyperbaric oxygen therapy as a treatment modality. The best clinical trial, randomized clinical trial, was actually stopped early several years ago because there was no benefit for hyperbaric oxygen therapy. So it doesn't particularly hurt to try, other than it delays care often, but the data is not there that it is overly helpful. And so where I did my fellowship, and I've done a few patients here, this has really revolutionized people with osteoradionecrosis. And it's something that's not widely known in the dentistry world, the oral surgery world, or the primary care world. So people can have the bone essentially will get infected and it can start to break down. And this patient, I saw him yesterday, and he's healed it even more since then. He looks awesome. He had tonsil cancer 2015. And so he got radiation and chemo. He's done great from a cancer standpoint, hasn't had any recurrence. But recently he was found to have exposed bone in this area. So that's a problem because bacteria and fungi can set up shop here and eventually break down the bone. Historically, we've tried antibiotics, we've tried hyperbaric oxygen therapy, we've tried some other medications, but they haven't been that helpful. And so the only other option historically was to do a big surgery to where we take out a big segment of the bone, we take the fibula, we take the scapula, we reconstruct it. We often have to do a trach, a feeding tube. They're in the hospital for 2 weeks. Where I did my fellowship, my mentor over the past 12, 14 years has developed a thing to where we take a transplant from another part of the body, so still a graft, but it's only fascia and blood vessels, so it's much more limited in scope. The surgery is about half the length of time. We do limited access incisions, and so I made a very small incision in front of his ear to find some blood vessels. This is his graft here. He's healed beautifully, and then now you can't even really tell. But the reason we do that is because when people have radiation, the blood supply to this area is limited after radiation. And so the thought is that we just need to supply a healthy bed of vascular tissue with new blood supply to help eradicate the infection. And so what we're able to do is remove the diseased bone while keeping the rest of the bone stock in. We clean it all out. I think I took out 2 teeth on him. And then I put a very small graft in here. He left, I think, day 3 after hospital stay, maybe day 4, whereas he normally would have been in the hospital for 2 weeks, and he's doing great. He said he had no issues yesterday. He was very pleased with the results. And so it leads to lower risk surgery, shorter hospital stay, and people in the series that my mentor produced, they have a 96% success rate. So people can have really great outcomes. So that's the example there. And so now we're switching to radiation therapy. So radiation therapy is a very common treatment modality with these people. Sometimes it's their primary treatment, sometimes it's combined with chemo, or sometimes it's all 3, surgery, radiation, and chemo. And so I'm not a radiation oncologist, so I'm going to keep this very basic, but there have been significant advances with what we call IMRT in recent years. And so they have been able to limit the radiation to the surrounding tissue. So if you took it 20, 30 years ago when people got treated with radiation to this area, they would have significant morbidity, net quality of life, range of motion, shoulder dysfunction, swallowing, speech, because the radiation would target. So nowadays they're much better at targeting, and that makes it much better for our patients long-term. Improves the therapeutic index. So it's targeting the tissue that we need to target while limiting the tissue that's healthy and not damaging that tissue. It decreases morbidity in the short term and long term. And so we're able to decrease dry mouth, or what's xerostomia. We're able to lessen the pain. dysphagia, trouble swallowing, and overall lethargy, or people getting tired. When people get radiation to full dose, they get pretty tired a couple weeks into radiation. That can last for an extended period of time after radiation, but they've gotten a lot better at being able to target that nowadays. And our radiation oncology group here is wonderful. And one of the things that we are partnering with the radiation department, it's a relatively new trial in the past few months, is almost every single head and neck cancer patient that has radiation to the head or neck will get some form of dry mouth. It's inevitable. Dry mouth can be really debilitating to people, as you can imagine. And so there's this clinical trial that we have enrolled in to where essentially we can inject a gene, aquaporin, human aquaporin 1, that can hope to make the salivary gland cells more permeable to water, so increase someone's saliva production. The long-term data on this is not known, but the hope is someone, they get a few years out from cancer treatment, are doing well, we can inject these people and it would decrease their xerostomia, which that's really important not only for quality of life, but changes to the saliva production in the mouth can affect your dental health, infections, quite a bit of things. So it's not only saliva is important for more than just having a moist mouth. And systemic therapy. This is a very broad topic, and I don't have time to go into detail. And our medical oncology department here is wonderful too. So, which patient would be most inclined to have chemotherapy as part of their treatment approach? A 33-year-old non-smoking female with a small cancer in their mouth, a 55-year-old male with a cancer of their salivary gland and in their lymph node, a 70-year-old male who's a truck driver who has a small skin cancer on his left ear, or a 49-year-old who's an alcoholic who has failure to thrive, that has cancer in their jawbone and both sides of the lymph node of their neck, involving their skin, who would need a lot of care to try to help to get them to survive. Okay, it would actually be D. So the reason is the parotid cancer is salivary gland cancer. And as far as we know nowadays, chemotherapy is still not a great agent for salivary gland cancer, so we only use it in reserved settings. The question I was getting at was 49 was this person, oftentimes I had a patient like this, that's what it was based off of. He was an alcoholic and failure to thrive, and he was not ready to undergo surgery for a variety of reasons. So we admitted him to the hospital, and one of my medical oncology colleagues treated him with chemo up front to help decrease the burden of disease, and then we did surgery, and he's done well from that. They would also get chemo on the back end, often in this setting, so it would be D. And so systemic therapy, it's historically not worked too well. It's only given a very minor benefit to head and neck cancer treatment. There's a potential for high-grade toxicity, and so we've often reserved it for locally advanced, as in that person in D, or recurrent disease when someone either may not be a good surgical candidate or surgery would be heroic. We need chemo to try to help us out. But there has been a shift, so systemic therapy is shifting nowadays because we have immunotherapy. And we're starting to potentially get a better understanding of how can we use chemotherapy or immunotherapy or both in the neoadjuvant setting. So before maybe what we call definitive chemoradiation or definitive surgery. It's a really promising area. And so this was a paper that came out a few years ago that looked at, so nowadays we use pembrolizumab a lot, so PD-L1 therapy, and our new cancer director, Dr. Ferris, is an expert in this. And so he's one of the leaders in this field. And so essentially what we do in people with this type of advanced or recurrent disease is we get what's called a CPS score, combined positive score. And essentially if they're elevated, the numbers elevated, we have maybe more of a hope that they would have potentially a better treatment response. And so often people that come in, we'll give them immunotherapy and systemic therapy if they have recurrent locally aggressive disease or they present with distant disease. Their overall survival in the study was a little bit better. Now, some people would look at this and say, a couple months is not much better. You're right, it's not much better, but we try to maximize someone's life and quality of life if we can. And so if we can give someone a few more months with their family and friends, some people find it really meaningful. And so we have a trial here that's looking at immune checkpoint blockade, where people come in with locally advanced care, and we treat them with immune therapy and what's called PARP inhibition. And that's to try to see if we're going to have any change in their outcome, and they get pre and post CT simulations. And so some of the clinical trials we're doing here, one is called nanobotics, which is really cool. Me and my partner do the injections for these. So this is for someone who's going to get radiation more in the palliative setting. And so what we do is we inject a radio tracer before they get radiation. And the goal is essentially to try to help maximize the effect of their radiation. We've actually enrolled the most patients in the United States. And then there's another one, I think it's a phase 0, where we actually inject the tumors. And so companies and researchers are interested, can we inject the tumors with these microdoses of medications or gene therapy to potentially see what the tumor looks like on the backside, on the histopathological side? Still far off from treatment, but it's a promising clinical trial area. We do select a lot of biomarkers for HPV-mediated disease. This is a very significant part of how we treat patients nowadays, something called NABDX or ctDNA. Sentinel lymph node biopsy, like we've talked about, and then immune therapy and vector therapy. And then last thing, and we have time, we'll go into the thyroid. I'm not sure. Tim, how are we doing on time?
We are, let's see, let me look. We have about 6 minutes before we should get to Q&A.
Okay, sounds good. So if someone's makes it to the other side and survives head and neck cancer, it's a huge thing on their part. It's really impressive. And so in the post-treatment rehabilitation and survivorship area, it's a whole team of people. It's not just the physicians. So we need speech therapists, nutritionists, physical therapists, occupational therapists, mental health. A lot of head and neck cancer patients struggle with anxiety, depression, struggling to go back out into public or to see their friends or their family because of potential changes to the look or their face or their speech. And so, it's not uncommon that us as surgeons are trying to get people in for mental health or starting them on antidepressants, anti-anxiety because of this. Transportation remains a significant issue. The physicians involved, it's a whole group of people. It's not just one of us. One of my mentors does a lot in survivorship. And so he did a study in 2020, and he saw that few survivors often recall their discussion of their cancer care with their PCP. So clearly an area where we need to improve upon, where people become more comfortable talking about head and neck cancer care afterwards, because us as the surgeons or radiation oncologists, medical oncologists, we have to have other people help us out to try to make sure people are doing well, even if their cancer doesn't come back, but also helping to try to survey them to make sure they don't get development of recurrent disease, because we don't want people to fall through the cracks. And so the last thing I'll briefly touch on is thyroid cancer. This is often it's a different disease. I have 2 thyroid cancers today. It tends to happen in younger people. It can be very healthy people. I have a 38-year-old female, and then I have a 19-year-old female today. So much different demographic. Neither one of them smoke. The incidence of thyroid cancer has gone up dramatically in recent years. And the reason why is, let me pull back. The incidence has gone up while the death rate has stayed very low, which is wonderful. So it's still about a 98% survival rate, 95 to 100%, 95 to 98% survival rate at 10 years, which is excellent. The reason we've caught more is due to imaging, so incidental findings, people having more ultrasounds, FNAs, and the majority of the tumors that we take care of are small, so less than 2 centimeters, less than 1 inch. And it's a shifting field as to how do we take care of these small cancers. Some of these small cancers people may never pass away from, but do we need to be aggressive? Do we need to be less aggressive? So it's something we're always thinking about. And in the primary care setting, this is an important thing that people often come across. You can see if people get definitive treatment, the outcomes are excellent. There's still morbidity involved, potentially. Even if sometimes people don't get treatment, the survivor can still be good. In some countries, for example, South Korea, if they have microcarcinomas, cancer smaller than 1 centimeter, some people don't even get treatment. They just follow it with imaging. The types of thyroid cancer, the most common is papillary thyroid cancer. Then there's follicular. There's other rare entities such as medullary thyroid carcinoma. Occasionally, we'll see metastatic disease to the thyroid or lymphomas. Those aren't treated surgically typically, but we still have to diagnose those. And so this is an example of a case I have later today. of a patient with a thyroid cancer here that's grown rapidly, and it's potentially involving her airway. So she's not only going to need her thyroid removed, we'll have to see whether or not she could need something called a tracheal resection, which can be a major surgery. And then this is another one where the thyroid's enveloping the majority of the neck here. And so these can be troublesome, but their survival outcomes are still quite good. The mainstay of treatment is surgery, whether that's removing half or all of the thyroid gland. The majority don't need their lymph nodes removed, but some people do. And then a lot of treatment also revolves around what's called adjuvant radioactive iodine, which is different than the standard radiation. So less often people get external beam radiotherapy, so traditional radiotherapy. Less people get chemotherapy or immunotherapy. There are select patients that we do targeted therapy for if they're BRAF positive and have aggressive disease, for example, or something called anaplastic carcinoma. And then these people are followed long-term with biochemical testing. We follow their laboratory, their TSH. And then we get serial ultrasound, so cervical ultrasound's the gold standard. And then other imaging, CT, PET scans, those are less common in the setting. Ultrasound's typically the gold standard. Okay. I think that's it. 10.
All right, Dr. Sullivan, this has been fascinating. I want to remind everyone to share your questions via Poll Everywhere. I've probably got 40 minutes worth already jotted down. I know we're not going to get to all of those, and I want to prioritize our guests over my own questions. But this has been great. Let me go ahead and just advance to there where we'll be taking questions, and I'll go ahead and promote those as we receive those. Let me ask one at the beginning, because this is going to bug me until I know the answer today. You were talking about the free tissue transfer and taking a part of the fibula. So when that piece of bone is taken from the leg, what goes in place of that I'm assuming this is not a cadaver. This is for the actual patient.
Yeah, the gold standard is live tissue. Cadaveric bone used to be used, but the resorption rate's high, the infectivity rate's high, so we never use it for large reconstruction anymore. Okay. You actually don't need your fibula for the most part. It's considered a vestigial structure, so we always leave a segment of bone for the ankle joint and the knee joint to keep stabilization, and then all the bone in the middle, we can take 12, 15 centimeters at least, and that bone can be discarded, and someone can walk the next day. We put them in a boot for a few weeks, but they don't need that bone. It just their joints are stable. We keep 6 centimeters on each side, and they do fine long term. Some people, the 34-year-old was my first one for a problem, and he was back to running. I've done a 16-year-old back to running, so they do great long-term.
Okay,
typically.
well that's good. That won't bother me anymore. I'm a technologist, not a clinician, so thank you for explaining that. All right, we've got some coming in from the audience, and we thanks to the audience for starting to share these. Can late-stage HPV mediated disease be cured?
It's a complex question. So historically, the overall survival for HPV mediated disease is better than HPV negative disease. The caveat to that is we tend to see people that have a strong tobacco history in the HPV mediated disease. Their survival advantage is often negated. So they do not survive as well as someone who's a non-smoker. If someone late stage disease can be locally advanced disease, so it's not distant, but they have cancer in the lymph nodes of the neck. Those people, they can still have very favorable outcomes. It's when there's biopsy-proven cancer distantly, so their chest or their lungs or their bone, when we don't think of it as curative when we start to take care of them, so we usually don't do surgery, but they can still have very robust responses to select radiation and systemic therapy. And there are some people they'll be alive for a few years. But anytime it's advanced distantly, we don't think of it as curable.
Great, thank you. And related to that, is lymph node neck dissection still necessary with HPV mediated disease?
Yeah, certainly. So the majority of people come in, it'll often be a person that's a little bit older than myself that'll come in with a neck mass they've had for a few months. Excuse me. And then, for example, tomorrow, the lady, she's 70. I think she had a neck mass, and then she has a small tonsil cancer. And so sometimes people can have a tonsil cancer as small as 2 to 3 millimeters, but the cancer in their neck can be 4 centimeters, 5 centimeters. And so the cancer in the neck is actually the bigger problem. And so, yes, if we're going to do surgery on these people, the neck dissection is probably more important. It's a long area interest of research, but yes, we still do neck dissections.
All right, thank you. And another question, what do you think will be the next big leap forward with head and neck cancer?
Um, I think it's going to be a combination of better biochemical testing. So things such as ctDNA and being able to stratify people. So one of the things we try to stratify people and then also determine can we shift away from surgery? I'm a surgeon, but surgery can still be quite morbid. So can we stratify people with genetic testing or blood testing to figure out who are the people that aren't going to do as well, even if we do all the treatments? If they have a specific mutation, those people would need more intense treatment, and the person doesn't have a mutation. Can we give that person immunotherapy? Can we do a limited surgery? And that seems to be where the future of our field lies.
Great, thank you. And is there significant difference in the ability to clear the margins in head and neck surgery between robotic and open surgery?
Yeah. Yeah, robotic surgery is challenging from a margin standpoint. Part of it's the location. Uh, and so a lot of times when we're clearing margins on robotic surgery, like I have to do tomorrow, one of the margins is typically only 1 millimeter or less. And that's because right next to it is the deep structures of the neck, including the carotid artery. And so we can't be as aggressive in that area. The good news is those people tend to do better, so we don't have to be as wide on our margins. But either way, whether it's robotic surgery or a larger open surgery, margin status still is a challenge even for the best of surgeons.
Gotcha. And I will say I was surprised you mentioned that haptics are still a few years away. You know, considering
Yeah.
that we're getting more haptics even in our phones, that's just not quite there yet for the robotic surgery.
Yeah. For example, when we take a tonsil cancer out with the robot, you can usually see the area that's facing you well and the
Mhm.
sides. And so as long as you visually cut far enough away, you're not going to get into the cancer for the most part. But what we call the deep margin, a lot of times the way we clear a deep margin or the margin under the tumor, we want to feel that to see does the tissue feel normal underneath it. And so we can look at it, but we can't feel it. And so that's where you have to sometimes take a best guess almost and think that you've cleared the tumor. And that's an area that if we get a positive margin, it's often on that deep margin to where we don't have the ability to fill it.
Gotcha. Gotcha. Well, excellent questions from our audience. I apologize we don't have time to get to everything, but we really appreciate those questions. We are at the hour, so I want to go ahead and say a few thank yous and go ahead and wrap up. We want to say thank you to University Cancer Research Fund from the state of North Carolina, to the UNC Lineberger Comprehensive Cancer Center, to our team, Benny Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, and Barbara Walsh for all of the work that they do to make each of these lectures possible. Thanks to Don Poe for the music back roads at the beginning.